Next case, sequential visual losses, initial symptoms presenting before cutaneous manifestation of SLE. Dr. Chaitanya YV Krishna.
Good afternoon, respected members of the panel and dear colleagues. My patient is a 30-year-old woman who presented to us with chief complaints of loss of vision in her right eye for 1 month duration. The history dated back a month back when at the onset she had pain and vomiting, and 10 days later she consulted elsewhere with the vision as documented, but the right eye diminution of vision progressed further, and when she came to us she had a PL negative vision with RAPD and no other significant findings in the anterior segment. On fundus examination, there were patches of retinal opacification and multiple dot blot hemorrhages in the right eye, while left eye was essentially normal with mild tortuosity of vessels, some sheathing in the superior peripheral vessels, and a cotton wool spot. An angiography was performed which showed marked areas of capillary non-perfusion. There was macular ischemia and diffuse vascular leak, predominantly involving the veins in the right eye, while the left eye was within normal limits. The right eye OCT showed PAM, macular edema, and subfoveal fluid, while the left eye was normal at this point. Occlusive retinal vasculitis, right eye was diagnosed and prophylactic PRP was performed. Immunosuppressant tablet prednisolone was started. A rheumatology consult was also sought with the following labs, but the patient came back to us 2 weeks later. She was lost to follow up in the meantime with a profound loss of vision in the left eye as well. We performed a general systemic examination which was found to be fairly within normal limits, and now she had a denied PL vision in both eyes. RAPD continued to persist in the right eye. We have a right eye with occlusive retinal vasculitis well lasered, while the left eye continued to show essentially normal findings. OCT in the right eye showed resolving features of the earlier features, while left eye continued to show normal findings. Fluorescein angiography with this time more focus on the left eye was performed, and we noted a delayed filling of arteries which showed at 17 seconds, and arterial filling was more delayed in the inferior arcade as compared to the superior arcade. Rest of the findings were essentially normal. This was a bilateral sequential complete loss of vision. The patient was admitted and started on IV methylprednisolone, and a neurological consultation was also sought. In the meantime, investigations were performed. The hematology biochemistry was essentially normal. However, ESR, CRP were significantly raised, and ANA was positive at 1:160 titers. Rheumatology consultation, a thorough examination revealed no systemic features of connective tissue disease, so they advised us to continue what we were doing, and some additional investigations were ordered which also turned up negative. A neurological consultation ordered a thorough imaging including carotid Doppler which was normal, while a CSF analysis revealed a higher than an opening pressure which was towards the higher range of normal, and therefore tablet acetazolamide and certain couple of therapeutic lumbar punctures were ordered. However, CSF analysis was essentially normal. So the course in the hospital in the left eye started showing improvement after each therapeutic tap and IVMP that we did. And at this point, we considered a diagnosis of idiopathic intracranial hypertension without papilledema, which is an extremely rare, however, a reported condition in the left eye. On day 10 of admission, the vision in both eyes had started improving. The right eye has also improved gradually to counting fingers, with the fundus findings remaining the same. As the vision in the left eye improved to 6/9, we performed a visual field also, which had a doubtful reliability but showed intact fields. And 6 months later, while the patient was consistently being followed up, the patient suddenly manifested erythematous cutaneous maculopapular rash involving the malar region and the back. We dug deeper and found anti-Smith and SSA antibodies to be positive. This was a bilateral sequential vision loss secondary to SLE. The patient is still under regular follow-up, started on hydroxychloroquine. Cases with diagnostic dilemma like this need to be dealt with an aggressive and a multidisciplinary approach. Thank you.
And thank you for that very interesting case. So I'll go to the panelists if they have any questions.
MRI was done in this case? MRI?
Yes, ma'am. Contrast enhanced MRI as well as MR angiography. As we were at our wits and what is happening, we did go, and this was all with the neurological team in picture.
Okay.
And it was normal, ma'am.
Normal. So then the neurologist opinion for CSF, as you have labeled that benign intracranial hypertension.
Ma'am, so like I said, it wasn't grossly high, the opening pressure, but it was higher than the upper limit of normal range. And therefore, because of the symptomatic status of the patient and because of certain other clinical clues which the neurological team found, her general body build, her general emotional state, they leaned towards the diagnosis of IIH and went ahead with the acetazolamide, which they continued for 3 months.
But that 3 months course of acetazolamide did not help. It did not help. No?
Sir, the acetazolamide?
Yeah.
Sir, we believe that the acetazolamide as well as therapeutic lumbar puncture did play a role in her improvement of the left eye condition.
Okay. And how has been the course on hydroxychloroquine, which has been
Sir,
started?
she's still on. It has been continuing 300
What is the
mg
visual
twice a day.
status? What is the visual status now?
Sir, so in the right eye, the one with occlusive vasculitis, she's counting fingers. And in the left eye, it has improved to 6/9.
6/9. Okay.
Okay, so any other question from the audience? I had one question for you. So I have a bit doubt about the right eye diagnosis. So you said it is PAM and the patient was denies PL. So how do the two tie in?
It was hard to correlate, sir. That is why we went all in with the treatment. We did PRP right at the first sitting. It was measured. I did the vision myself with an indirect in a dark room. It was denied PL, sir.
Yeah, so I can agree with that the patient was PL negative. But the important point is, when did you see the patient after the symptoms began?
Correct,
So
sir.
it is most likely a central retinal artery occlusion that has occurred because you see patchy areas of CNP loss that was there. That led you to do the PRP later on, not the PAM. And initially, it might even have been an ophthalmic artery occlusion
Ophthalmic
because of the inflammation.
Sir.
Because normally your PL is preserved in central retinal artery occlusions,
Absolutely,
right? So you might have been seeing it at a later stage when the artery has opened up, and that is why you see manifestation on OCT looking like PAM. But in the initial stage, it would have been a complete whiteout.
Absolutely.
That
sir.
explains. So we can move on to the next stage.